Welcome to our first speaker session, Issues with Children in Clinical Research. Dr. Fasipe is an assistant professor in the Department of Pediatrics, section of Hematology Oncology at Baylor College of Medicine. Her goals are shaped by her desire to help children facing the hardships of a blood disorder, particularly those patients with sickle cell disease who continue to have significant comorbid complications and decreased lifespan. In addition to Dr. Fasipe's academic role, she is actively involved in various sickle cell-focused community efforts, including her appointment to the first Texas Sickle Cell Advisory Committee from 2016 to 2018, and her current role as chair of the Houston Sickle Cell Collaborative, a joint effort between the Houston Health Department and organizations vested in sickle cell disease. Dr. Fasipe, thank you for being here with us today. Turn it over to you.
Thank you so much. I appreciate the invitation to present today. Good morning, everyone. I'm Dr. Titilope Fasipe, and I'm so excited to be here. Today, I'm going to focus on issues with children in clinical research. These are my disclosures, and I will say that it's not like I have stock or anything in these companies, but actually my role is to help industry stay accountable when we're doing clinical trials that are sponsored by drug companies. And so that's what a role for a physician to be a consultant. And I also have some grant funding. So let's do a mini review. We just heard an excellent presentation from Dr. Olaleye about the phases of clinical research. And she excellently walked us through all the various components of that. So I'm not going to belabor that point. And then prior to that, we heard another wonderful presentation, an eye-opening one from Dr. CREC. I learned so much, and I thought I knew a lot about ethics in clinical research, but I still learned something today. And many of the words he discussed are kind of in this little graphic. The one I want to focus on today is the one in the middle, vulnerable subjects. And in this case, we're going to focus on children. So why are children vulnerable? Well, they're not at the legal age to give consent for research. And I believe Dr. Rouse, our next speaker, is going to kind of go into what that looks like in detail for everybody. But for children, you know, not being of legal age, and I put a star because for Texas, legal age is 18 years old, but there are certain states that have a different age, and certain countries might have a different age as well. So we need to protect the vulnerable. That's how I see it, especially since I'm a pediatrician, a pediatric hematologist. So even knowing that we need to protect children, that does not mean that children cannot participate in research. In fact, they can. However, we have to be careful. First of all, you get their champion involved, and in this case, it's their parent or their guardian. The parent and guardian can help the child for the legal component of the consent. However, we don't want to just ignore the child. We also want to make sure the child understands to the best of their age what is going on and get what we call their assent, which is a version of consent that says that, hi, I know that I'm enrolling in this trial, and I understand for an age-appropriate level what the trial means. And with the parent can discuss the components that you saw in the skit, how to participate in the trial, and if at any time, if the parent and child want to remove themselves from the trial. And then even with the parent consent and the child's assent, there's the regular criteria that you heard discussed by Dr. Olaleye and I believe the next speaker as well. But there's also some special criteria to keep in mind, and let's review those together. So there's 4 different situations that will make it okay or appropriate for children to participate in research. First, if it doesn't cause any harm or less than or equal to minimal risk. And minimal risk means whatever the typical daily risk is in our lives. So they already have their appointment, they were already coming in. And so you're only maybe doing a survey type of research where the parent and the child may fill out questions or take part of a poll. That is considered research too. But the reason why it's minimal risk or less than minimal risk is because it doesn't cause any pain or extra intervention. You're not giving a drug and you're not taking any blood or anything like that outside of what is normal care for the child. Another type of research that is slightly greater than minimal risk, but you know that it provides direct benefit for the child. So let's say we already know a therapy already works for a certain disease that we've tested in adults, and now we want to give it to children. There is a slight chance of risk because it is a new drug in children, but you know that it's going to address that disease process. And so it's important that we help the child become better. And so sometimes those studies will tell the family that, yes, this trial might have a little bit more than minimal than risk, but we see the big direct benefit. And then the family can decide when they compare the benefits and risk, whether this is appropriate for their child. I use the example of a therapy already approved in adults. That's usually the most common version of this. But sometimes there's also things that are maybe immediately life-threatening to the child that maybe only occurs in children, like certain types of cancer that might have a trial as well. And let's go to the next one to kind of expand on that thought. What if it has greater than minimal risk, but there's no direct benefit to the child? How do you wrestle with joining a clinical trial like that? The only way we can think of it as being ethical is if that trial can increase knowledge about the child's disease, so that even if the child can't benefit, a future child with the same disease may be able to benefit. This is very common in cancer research. We all know cancer is a very difficult condition, and there's so many different types of it. We're happy that there's so many that we can treat, but then there's some that get very tough and we need to figure out smarter ways to fight it. In those circumstances, we don't want to overpromise a benefit to the child or to the family. So we say right up front that we're not sure if this is going to provide direct benefit. The only thing we are sure of is that it'll increase knowledge about the disease. And so this one is much tougher to engage in, but I work with Dr. Rouse, who's our next speaker, and we take care of kids with blood disorders and cancer. And a lot of times we discuss these very trials with them because we want them to know that some of the medications their child took, other parents from years ago agreed to the same type of trials so that we could learn how to fight the disease better. So to me, these three seem like enough. This is pretty heavy. You know, the first two, maybe we get it. The third one is something we don't ever want to be involved in, but you can understand why some families will accept that. So what about the fourth category? The fourth category says, serious problem affecting health or the welfare of children. So this step is not one that you can take lightly, and no doctor or no researcher can wave a paper in front of a family and say, hey, sign up for this. This one requires a national government health official to review. And what would compose of a serious problem? Well, we're living in one right now. We have the COVID-19 pandemic, but then there's other pandemics that could occur, or other big serious problems that are health crises that sometimes we might have to think of the welfare of the child above all else. I will say that this is very, very, very rare. Even in our pandemic, I believe there was a question and answer question about the COVID-19 vaccine. Even then, you notice that we put adults before children. But if there was ever a time where we felt that the problem was going to hurt many children all at once, it is sometimes worth investigating a trial that can save them. And so this takes a lot of thought process, and it would only be in the unique circumstances where a whole bunch of children would be affected at the same time. And I use pandemic because that's usually the best case scenario. That's the best example, excuse me, of how a lot of people can be affected all at the same time. So I'm going to use an example from my world. I mentioned that I am a doctor that takes care of children with blood disorders and cancer. And the main blood disorder I take care of is sickle cell disease. And I believe some of you may already be familiar with this disease. But I wanted to show you an example timeline of what it takes for children to participate in research. Dr. Olalia showed you all the things that I just snapshotted in this small component. Basically, before you even get into humans, you have to prove that the drug works in the lab and in various stages, as she went over. And then you can start phase 1 and phase 2 trials in adults, and that's what happened with hydroxyurea for sickle cell. They had seen that in the lab that hydroxyurea seemed to help sickle cell disease, but they wanted to make sure it works in humans. And so you started phase 1 and phase 2 trials. After that led to convincing information, and I'm going to highlight 1998 was actually when the drug was fully approved. But when they saw that it was working in adults safely, the companies and the researchers then submitted to the FDA, hey, we see that this is working in adults and everybody is okay. How do we start investigating in children? And so that's when those trials started. And so it would be an example of the one that's maybe greater than minimal risk because it's an unknown, but it can provide direct benefit to the child because they already saw that it provided direct benefit to adults. And so they started the first trials in children. But if you notice here, all of the rest of these say baby or children, baby, because they continue to make sure, what is this drug doing in children? Is it actually helping them? And now that the children are older, are we seeing signs that it actually helped them even more? And then they also looked at how it affects the disease. So they were able to see whether it helped with people at risk for stroke, whether it helps prevent organ damage. So you can see that even after a drug is approved, and I should have put a star right here, for hydroxyurea, it was approved by the federal government in 1998. It still was continued to be looked at in the post-marketing phase. And now it's used around the world to help people with sickle cell disease. So I'm going to stop here and thank you again for your time. I'm happy to take questions now or later. And I believe if there's questions down the road, Dr. Rouse, who's also a pediatric hematologist oncologist, can also help. Thank you.